Hello, and thank you for joining us tonight for Addiction Recovery and Plant Medicine, brought to you by the Education Committee of the Decriminalize Nature Arizona organization. I'm Dr. Oren Cox, and tonight I'll be the moderator. To give you a little bit of background, Decriminalize Nature Arizona is a coalition of people throughout the state who believe in the power of entheogenic plants and fungi and feel that nobody should be criminalized for choosing to use these substances. Part of our mission is inform our communities of these natural medicines and to support other cities looking for resolutions around criminalization. Tonight is part of our effort to help spread the word of these medicinal plants and mushrooms. Now, before we get started, a couple of housekeeping tips. To the right of your screen, you're going to see a chat box. So we invite you to chat during the session and share resources and ideas. And at the bottom of your screen, you're going to see a question box. So feel free to pose questions for our guests. And if you see your questions already been written, please go ahead and give it an upvote and feel free to upvote on other questions as well. Okay, so again, our topic is addiction recovery and plant medicine. And we're lucky to have Jennifer Montjoy here to share her knowledge and to answer your questions. So a little bit about Jennifer. She's a psychiatric nurse practitioner who has a practice in Tucson, Arizona called the Resilience Behavioral Health Solutions, where they specialize in complex trauma, treatment-resistant conditions, and post-traumatic stress disorder. Jennifer's a proponent of several therapy modalities, including psychedelic-assisted psychotherapy, and believes entheogenic medicines can be a catalyst for healing. In addition to her working as a psychiatric provider, she's a PhD candidate at the University of Arizona studying biobehavioral neuroscience and ketamine's psychospiritual and neuroendocrine immune efficacy in the treatment of post-traumatic stress disorder and complex trauma. Jennifer's excited to share her insights and information about the latest in plant medicine research and the treatment of addiction. So Jennifer, thank you for joining us tonight and welcome. And please go ahead and introduce yourself and tell us a little bit about what you do.
Yes, thank you. Thank you, Oren, for moderating, and also Stuart for hosting and inviting me. I'm honored to be here with you all. So I do have a private practice in Tucson, Arizona. We provide integrative psychiatric services, both virtually and in person. As Oren said, I use many modalities that support mind, body, and spirit, including nutrition, movement, supplementation. And we offer a holistic behavioral health care approach, in addition to Western practices based on client preferences. I do utilize psychedelic-assisted psychotherapy. I use this with ketamine in the form of a ketamine-assisted psychotherapy for treatment-resistant conditions related to depression and trauma.
So could you tell us a little bit about how psilocybin and other entheogenic components affect the brain when dealing with treatment-resistant conditions?
Sure. And I'll preface by saying, as I'm sure we all know, right now psilocybin is only legal in clinical research settings and in other countries outside of the U.S. So a lot of the information I'm going to share is research-based. And so entheogens target a lot of the same neurotransmitters that psychotropics or pharmaceuticals target. So serotonin being the primary one that entheogens target. One of the main differences that we're seeing and people report is the sensory alterations that accompany entheogens, right? So this is synesthesia, and also the temporary dampening of the egoic mind, also called the default mode network. These effects are unique to entheogens. And I think one of the reasons that we're finding that they're helpful in treatment-resistant conditions is because of these subjective experiences. So when the default mode network goes offline, that sense of isolation and disconnect that many experience who are chronically depressed or struggling with PTSD and other mental health conditions, that temporarily goes away. So they have some relief. And it's, they report a sense of connection during the psychoactive phase after, ingesting the medicines, the molecules. And I think, when entheogens and, these medicinal plants are treated as sacred medicine in appropriate settings, including, ceremony, that the sense of connection and self-transcendence facilitates psychospiritual healing. And I think that that's an aspect that's missing in currently available psychiatric settings.
Excellent. Thank you for that. Now, you said that you do ketamine-assisted therapy in your clinic. So how does that relate to plant medicine?
Sure. So, I think there's a lot of stigma around ketamine as a medicine. Obviously, it's not a plant, a natural occurring molecule, but in subanesthetic doses, with ketamine, we're able to induce non-ordinary states of consciousness, and clients, research participants experience psychedelic effects. So in my practice, for example, I administer ketamine intramuscularly. So people aren't tethered to a lot of devices. And similarly to the experience that's been reported with entheogens, people experience what they describe as a journey. So there's a sense of traveling, of going somewhere beyond the here, the physical, and now. And there's a sense of expansiveness and self-transcendence and timelessness also. Additionally, people report a stronger sense of connection, both connection intrapersonally, so within, and also transpersonally. So a sense of connection to others and to Mother Earth and the universe at large. So, different molecule, different mechanism of action than most entheogens, but somewhat similar experience reported.
Excellent. Thank you for clearing that up. So speaking of stigma with the ketamine, what about addiction? Can you tell us a little bit about what addiction is and what it is not, and also address the stigma that's associated with addicts and addiction? Sure.
This is a great question, and really, I think, at the heart of why we're here tonight. And I'd like to kind of start with the word addiction, and this is derived from the Latin word addicere, and what it means is bound to or enslaved by. I think that it makes it easier to distance ourselves from, the dirty word addiction when we associate it with substances, many of which none of us will ever experiment with, like heroin and crack, cocaine. And so I think some of the stigma arises from that. And so the sense of separateness from those people, those addicts that do those things. But in reality, the truth is that addiction applies to most behaviors from which pleasure is derived. So the nature of addiction is that we persist often in a compulsive way to do or consume these things with the knowledge that in doing so, there will be negative consequences, potentially. And so, for example, some behaviors are gaming, porn consumption, buying things, purchasing a lot of items, online shopping, gambling, and even social media. Like excessive substance or alcohol use, these behaviors can potentially fracture relationships, lead to job loss, and or financial ruin. And I'd like to make one other distinction, and that's the concept of dependence. And so with dependence, there's physiological dependence. This usually involves signs and symptoms that arise when the substance is stopped abruptly. So withdrawal symptoms. And substances that come to mind are like opioids, right? So prescription pain medicines, benzodiazepines, things like Xanax, Klonopin, and alcohol. But there's also psychological dependence, and this is the belief that we're not able to function without doing these, these behaviors, like I mentioned, gambling as an example, or consuming these substances that, we're not able to live day by day without participating in these activities or consuming these things. So a person can become dependent sometimes in benign ways, like being prescribed pain medicine post-procedure or post-injury. They may take the medicine as prescribed, and if they take it long enough, they will physiologically become dependent. It doesn't mean that they're misusing it or that their behaviors are addictive in nature, but there are some substances that if we take them long enough and take enough of them, then we have to taper, we have to gradually discontinue them, or else we become sick. And with some substances like benzodiazepines and alcohol, it can be potentially dangerous.
Excellent, thank you for that. So digging a little bit deeper, like neurologically, how does addiction work in the brain?
Sure, and so I have a couple of slides I thought that would be helpful, and I'm gonna, just bear with me a moment, you guys, I'm gonna pull these up. All right, and Oren, can you guys see this? Sorry, Oren, I didn't hear you. Are you able to see the slide?
It's ready now. It's the full screen.
Okay, all right, thank you. So the question, neurologically, how does addiction affect our brain? How do we become, addicted? And so I have a couple of slides. So it does depend on the substance, but addictive behavior and substance dependence have been primarily linked to the neurotransmitter dopamine and the regions of the brain where dopamine is primarily transmitted. And this is also called the reward system. And dopamine here in the left corner is important for reward behavior, so motivation, pleasure, euphoria, and that doesn't have to be substance related. That can be sex, it can be chocolate, it can be having a glass of wine. Dopamine is also implicated in motor function, compulsion, compulsive behavior, and perseverating. This slide shows the reward system pathway, and this is comprised of the ventral tegmental area, the VTA. This is a cross section of the brain, by the way. The nucleus accumbens, and then the prefrontal cortex. And these are just a couple of slides that show the areas, the regions of the brain that are affected by, on the left, opiates, and then on the right, cocaine. So again, prefrontal cortex, the VTA. And our brain, I thought this was a beautiful picture. Our brain is comprised of approximately 86 billion neurons. They don't, in this image, they're illuminated by a special light, but getting smaller, here are 2 neurons. And these neurotransmitters, like dopamine, are transmitted from one neuron to the next via synapses. The synapses at the end release these neurotransmitters, so dopamine and serotonin and norepinephrine. And on a smaller slide, this shows what cocaine, how it works. And so I had shown you guys, this is the tip, the end of the synapse communicating with the receiving neuron. And so this is what we're looking at, the tip of the synapse communicating with the receiving, the receptor here on the synapse. And cocaine, what it does is it binds to the sending neuron synapses, so the one here on the top. And it prevents dopamine from being, for lack of a better word, recycled. And so our brain communicates via neurons, right, these synapses, with these chemicals. That's why they're called neurotransmitters. They're transmitting information. And substances like cocaine, opioids, block the reuptake. So there's a saturation of dopamine and serotonin and these other neurotransmitters in the synaptic cleft, so in between. And that's where the high, the euphoria arises from.
Going a little further, so is there a root cause to addiction that goes beyond just the substance, like that causes something?
Yes. Yeah, again, really a great question. So I think, in Western medicine and our biomedical model, we get really hung up on the physiology, right? The mechanisms of action and, the neurotransmitters and receptors. And, these are important things. They're important aspects of addiction and how, we understand, people who struggle with addiction. My perspective is a little bit more holistic as a nurse and nurse practitioner. And so I look at things through sort of the lens of, yes, physiologically, like, the slides I was showing you. There's also the epigenetic piece, right? So these are maybe predispositions, or these are, genes that are turned on based on our environment or our experiences, our stress, starting from in utero through life, that can change how our genes are expressed. But, another thing, and we kind of alluded to this earlier, was that psychospiritual piece. It's really not addressed in Western medicine. And, it's such a gap in treatment options. And I think one of my, again, biased perspectives is really aligns with Gabor Mate. And that's that addictive behaviors often arise from psychological and emotional trauma. For example, chronic childhood trauma, or PTSD that arises, post-traumatic stress disorder, which arises in adulthood. And when we're exposed to trauma long enough or intense enough, that reward processing, if you remember, the slides showing the reward processing, the three areas of the brain is blunted. So it's altered. So the ability to experience pleasure and positive emotions is dampened. And this increases risk of developing substance misuse in persons who have PTSD and or childhood trauma. Interestingly, depression and PTSD and addiction, they share many of the same neural circuitry. And so a lot of the same neurotransmitters that we're talking about, like dopamine and serotonin, are implicated in all of these conditions. they also tend to co-occur in many people. Depression, PTSD, and addiction are often co-occurring.
Brain does, like when using addictive.
Sorry, I couldn't hear you. First.
I'm sorry. Can you hear me now?
I can now. Thanks.
Okay. Just moving on a little further. So talking about how the brain works with addiction, how does it work with the plant medicine as opposed to addiction? Do you have anything on that to share?
Yeah, I do. So it depends on the plants. And what's interesting, most plants are, in regards to entheogens, are tryptamines. Tryptamine is derived from the amino acid tryptophan, and tryptophan, what may come to mind is the post turkey haze. For those of you that eat turkey, it's tryptophan, and it's a precursor to neurotransmitters such as melatonin and serotonin. And tryptamine is found in plants, fungi, microbes, and amphibia. And so I'm going to touch on some of the specific entheogens. So ibogaine, dimethyltryptamine or DMT, and psilocybin all contain tryptamine. Ibogaine is a tryptamine from West Africa, and it's derived from a shrub called the Tabernanthe iboga. I may be pronouncing that wrong. And it's been researched in treating cocaine, opioid, and heroin dependence. What's interesting about ibogaine is that it targets it's been found to target some additional receptors. And in this way, it's a little bit similar to ketamine. So it has an affinity for NMDA receptors, which are part of the glutamate matrix, part of the glutamate receptor system. Kappa, and so opioid receptors as well, nicotine, and serotonin. So in terms of, I think in terms of potential, clinical use, it's promising because it targets many different neurotransmitters. And it's also unique in that it has stopped withdrawal symptoms. So for people who are, going to different places like Mexico, there's, healing centers where I think it's legal. They're able to stop opioid use and within a short time frame receive the medicine, the ibogaine, and it stops the withdrawal symptoms that can be really miserable with opioid withdrawal. It's not potentially lethal, but it's very hard to abruptly stop opioids. So I think it shows a lot of promise, and hopefully here in the U.S. and I'm hoping near future. DMT is naturally occurring in plants found in South America, and then also in the secretions of Bufo alvarius, which is better known as the Sonoran toad. And DMT is also a constituent of ayahuasca. And so these things are serotonergic. Unlike ibogaine is also serotonergic, but it targets multiple receptors. From what we're understanding, these other molecules seem to be primarily serotonergic. And let's see, I've got another slide to share on this topic of plant medicines. Bear with me one more time. And then Oren, can you let me know if, can you see the slide?
Yes, I can.
Okay.
Yes, I can.
I appreciate it. Thanks. And so the amygdala here is an important part of the limbic system. Our limbic system is very important for emotional processing. So you can imagine with depression, PTSD, and addiction that the limbic system is an important aspect or component with these conditions, and mood and how we perceive things that are happening in our day-to-day, in our world. Psilocybin's been found to reduce amygdala reactivity to negative emotional stimuli. It's been also found to improve mood in depressed participants. So the amygdala is it's super important in PTSD as well. And that's it right there. The default mode network is shown in these slides. So the top three images are depicting the default mode network with placebo. So these are research participants that didn't receive a psychoactive medicine. And it's comprised, the default mode network is comprised of the posterior cingulate cortex and the medial prefrontal cortex. And that's the green dot here. Let's see there, right there. And the default mode network is, it's basically our autopilot. So day to day, that internal dialogue as we're going about our business. It's associated with habitual behavior. And so in the brains of the placebo participants, the medial prefrontal cortex, sorry, that's my pooch in the background, and the posterior cingulate cortex are connected. And that's what this is showing here. The activity is connected when the default mode network is online. After taking psilocybin, the areas associated with the default mode network become less connected. And this is depicted in the lower three images. So we can see that the blue is indicating a decrease in connectivity. In other words, the default mode network is taking a time out. And so this frees up our mind. It's less constrained by the concrete, physicality of day-to-day thinking and functioning. So with that, there's a decrease in that internal dialogue or chatter that plagues many. Psilocybin, as I mentioned, is serotonergic. And so it's been found to be serotonin agonist. And I'm going to back up. So what that means is an agonist opens up the floodgates. So the transmitting synapses here floods this space, which is called the presynaptic space there with serotonin. And that improves mood, can decrease anxiety, can help us to feel more contented. What's interesting about psilocybin is with the fMRI imaging is that we continue to see changes in the neurogenesis, the synaptic branching, days after the receiving or taking the medicine. So the benefits that we're seeing, and the research is pointing to many benefits, with mood, in addiction medicine, treatment-resistant depression. The benefits persist, and that's exciting.
we have a question from the audience, which may go along with this. So what do you believe has given these substances that are now being researched? I can't state what can the average person do to change this? Like just all these benefits, like scientifically showing how much it helps a person. Could you?
Sure. I'm sorry, I missed the first part of the question. I guess I can pull it up here, huh?
Yeah. Should
Substances that are.
Yeah. What do
Okay. So, what do I believe? So, the reason the stigma has arisen, I think it's a great question, and I think it's changing. I really do. I think, in terms of what you can do in the community, is just this, like what I'm doing, and that's educate friends, family, let them know that right now ketamine's the only legal psychedelic, and I say legal and clinical for clinical use. But I think educating people about these medicines, both the plant medicines and man-made psychedelics, is the main thing. Is just getting out there and spreading the word, and showing research, referring to Johns Hopkins, a reputable Ivy League school, right? And I mean, my gosh, the data that they're pumping out is just extraordinary, right? So I think just trying to, people who are interested and open to listening, because there's just always going to be folks that aren't, and that's okay. But for those that are, I think just like starting a conversation about it. I don't know about you guys, but it gets me excited, and I get pumped, and it is exciting.
Excellent. Thank you for that. So, how do you feel about people using plant medicine outside of a clinical setting, besides the legality part? I just meant for safety. Sure.
So, in the context of addiction, I think that this is a special category, for a couple of reasons. Mainly safety. There are several substances that are not medically safe to stop abruptly, even with plant medicine. Excuse me. So I think in terms of, again, the context of addiction, that there needs to be a medically trained clinician involved, at a minimum, to screen folks, to make sure that they're medically safe to undergo, like if they're going to go to a retreat in another country where some of these medicines are legal. Alcohol and benzodiazepine withdrawal, as I mentioned, can be a life-threatening situation. I've seen it in the hospital. It can cause dangerously high spikes in blood pressure, seizures. I saw someone seize withdrawing from benzos, and potentially death. So I think within the context of what we're talking about tonight, I do think that for substance withdrawal, that it's important to have a clinician involved. I think a reputable treatment center, whether it's within the U.S. or abroad, they are going to have medical providers screening. A lot of these places have, like, I know, Ibogaine resorts, I guess, they have, medical directors. And so people are screened. They're often interviewed virtually and or by phone. Their records are reviewed before they enter treatment. And I think that is important in terms of safety. I think the other thing, too, is, understanding that plant medicines, are not unequivocally safe. I mean, entheogens and psychedelics have been shown to have minimal risk, in terms of potential danger, but there are still risks. And so just as an example, there was some research about with animal models showing serotonergic neurotoxicity with chronic tryptamine use. So too much of anything is not a good thing, just to kind of make it simple. And that applies to plant medicines, synthetic psychedelics. These can cause, with large enough doses and enough use, they can cause damage to our brains. And I think it's important too to know what you're getting, right? That just it goes into doing research, being an informed consumer. Again, having conversations with people you know and trust about if you're considering, plant medicine or psychedelics. You want to make sure that it's obviously a reliable and safe source. So I think being an informed consumer is super important. Even in terms of risk, even over-the-counter plant medicines can be potentially lethal or interact with other medicines. So St. John's wort's, an example of that. Lots of data supporting its use for depression, but it does interact with a lot of other medications. So I think it's important too that if you're, considering, plant medicines, just to maybe, work with a provider that you trust, that's well-versed, with these medicines, it's open-minded, just to make sure it's safe. I would say, risk for an adverse event goes up with age. It's just the nature of the beast. So, maybe take that into account too. There have been some fatalities associated with ibogaine. And so I wanted to mention that in terms of safety. But these are associated with really high doses. It also has to do, I mentioned earlier, we talked a little bit about epigenetics. And so part of epigenetics is that we inherit enzymes from, they're based on the genes that we get, one set from mom, one set from dad. And how we metabolize these molecules, both from Mother Earth, so natural and synthetic, depends on these enzymes. And so what's interesting in terms of how long, ibogaine, the experiences, I don't, for those of you that have read or done some research, I found this interesting that, the psychoactive experience or, psychedelic can last anywhere from 6 hours up to 24 hours. It's this huge window. I would probably be one of those 24-hour people. But it has to do with what I'm talking about, these enzymes that metabolize these medicines. So if, for example, I'm a poor metabolizer of, some serotonergic molecules, it could be that it takes 24 hours for it to start to metabolize and stop, kind of get through that psychoactive phase. So again, I just, the other thing is that, there's risk of some arrhythmia. So just, I think, be informed, be safe, use common sense. I think that's the best advice.
Excellent. Thank you. Now, the next question I have, there's a question from the audience about what route of administration do you prefer for ketamine-assisted therapy? I know there's a couple different modalities, but I want to mix that in with, because I know a little bit of your background, with the question on how important is integration before, during, and after using plant medicine?
Right. And so, great question. In terms of, my preference as a clinician with ketamine is intramuscular for many reasons. I'm able to adjust the dose, so it's very individualized based on how each person metabolizes and responds to the molecule. I also like the intramuscular route because I'm able to administer, again, based on, the response of each person, a booster dose. So a second dose to augment and prolong the experience, because ketamine, for better or worse, is a very short acting, has a very short half-life. And so what that looks like is, 40, 50 minutes. That's with both doses of a psychoactive or, psychedelic experience journey. And so I like to have that. I like to have the ability to, to titrate and adjust according. We can really fine tune it when we're using the intramuscular route versus oral. We don't have as much. We're not able to fine tune it as much with the troches, which are the dissolvable. They taste really bad, really bad. And you have to hold them in your mouth for, 10, 12 minutes. It's rough. And there's a second pass. So there's some confounds that, I like the precision of the intramuscular experience. So, and then to the question about integration. So I think it's absolutely essential, regardless of the medicine. And, we're seeing all this, again, amazing data coming out of Johns Hopkins and MAPS, right? And I like to mention, and I'm going to have on my website under resources, I'm going to have links to some of these things that I'm talking about, like Dr. Mate's website. He really is an expert on addiction medicine, and I align very, very, very much with his philosophies about it. The other link I'll have as well, or the article that with the psilocybin. I'll have a link for that article on the resource page of my website. But going back to the question about integration, so the MAPS protocol, a lot of people, I don't think have maybe had the opportunity or exposure to read, but so phenomenal results, outcomes post MDMA treatment up to a year. And what's interesting is that the protocol is the participants receive the MDMA. They receive it once every month over the course of 3 months. So 3 medicated sessions, right? But they participate in 9 90-minute integration therapy sessions. 9. That's quite a bit. They also, in addition to that, this is per the MAPS protocol, are participating in 16 telephone check-ins. So there's only 3 sessions with the MDMA, but there's a lot of integration work. And so I do believe that, a lot of the results are subsequent to the integration work and the preparation as well beforehand.
On that same note, considering microdosing, so do you think microdosing alone helps, or is subsequent counseling needed for the duration of its use?
So there's not as much data available on microdosing. I think there are several studies. I know the Imperial College right now, I think they're doing research on microdosing of LSD. I want to say like one of the University of California satellites is also, I think they're doing maybe some microdosing psilocybin research. But from what's available that's been published, there's not a whole lot. And so I can't really speak too much to the efficacy of microdosing, but I can say this, and that's, based on my experience in mental health care, so many conditions have roots in trauma. They're, old traumatic wounds. And so arising from that are anxiety, depression, symptoms. And, these wounds didn't occur in isolation, right? It's my feeling that healing doesn't occur in isolation either, that we're wired to, to heal with other people, with the assistance of other people and connection. And that means, I think, community, but it also, I think, can be helpful to have a coach that may be in the form of a healer or a therapist. And I do think that probably, and so I think, I can safely infer that people who are microdosing will probably have more robust and lasting results, and I think improve quality of life if they're incorporating integration.
Absolutely. Thank you for that. Now, do you have anything else before we're going to move on to the questions from the audience, but do you have anything else to say about harm reduction? I know we just talked a little bit about that. But.
Yeah, just briefly, I think in terms of harm reduction, again, working with a skilled and knowledgeable healer, right? And in cultures that means different things, that may mean clinician in, Western world, it could mean, a shaman in other places. And so I think in terms of harm reduction, preparation for the experience, for the sessions is important. Setting is critical. So, being in a safe, supportive setting. And then again, the integration piece, in terms of harm reduction. I think, a lot of times when people have an intense, or maybe they'll call it a dark or negative experience, they think, that it was maybe bad, the journey was bad or not healing. And, it's not necessarily the case. And I think, again, that's where working with a skilled healer, be it a therapist or a shaman, a guide, that's well-versed in integration and, processing. And that's, with the psychedelic-assisted psychotherapy approach, we talk about themes and archetypes and images, and sometimes they're scary, but that doesn't mean that there's not learning and growth, that can emerge from those experiences. So another great resource for harm reduction is on the MAPS website, and I'll post this also on my resource tab on my website. So they've got a whole page designated to harm reduction, and it echoes much of what I've just shared.
Thank you.
Yeah, you bet.
All right, so let's see what we got in the questions from the audience. Are there any of these plant medicines known to help with alcohol addiction specifically?
Yeah, it's a good question. And this is an emerging and evolving, field. It really is in its infancy. Unfortunately, it got kickstarted back in the 40s, 50s, and then kind of took on a life of its own in the 60s socially. But, things like LSD were being researched in clinical settings for alcohol abuse. Yeah, and so unfortunately, what happened, and I'm sure many of you guys, on this, on the, listening, tuned in, may know the history, but in 1970, the U.S. Congress made these substances, LSD, being one of the primary ones, illegal. Not just illegal for recreational use, but illegal for research. So for 30 plus years, until Johns Hopkins got the green light from the FDA to start doing clinical trials with psilocybin, we lost all that time that we could have been investigating many of these molecules. And it's so unfortunate. But to the question, yes, absolutely. If you do a little bit of digging, you can go back and find research on LSD and potential clinical applications for alcohol abuse. I think the ibogaine shows promise too, because it targets, right, from what I was able to find, similar to ketamine, it targets many more receptors. And I think that in terms of addiction, dopamine is super important. A lot of these, the tryptamines we talked about primarily target serotonin. So I think in terms of addiction, and that includes, alcoholism or alcohol abuse or dependence, I think ibogaine shows a lot of promise. And I think also maybe these other molecules show promise, these medicines, because they facilitate these psychospiritual healing experiences. And I think that's critical with addiction. There's so much shame, there's so much guilt, and low self-worth, and the sense of isolation, when it comes to, addiction and dependence, substance dependence. I think that these medicines can provide a break from feeling that sense of alienation and isolation. So I know that's a long-winded answer, but again, it's going to be a little while, I think, before we see these come to, clinical, like mainstream use in the States.
Kind of a follow-up question. So in addition to drug addiction, what other types of addictive behavior do you see being most addressed specifically with entheogen use? And are some of these addictive behaviors more helped by the entheogen use than others?
So again, not to skirt the question, but there's not a whole lot of research. We're talking like within the last 5 to 10 years. With ketamine now, which is it's synthetic, it's not plant. There are data supporting its use for different types of addictive behaviors, alcoholism, possibly opioid dependence. But in terms of the entheogens, from what I have read and researched and heard, I think again ibogaine, especially with opioid dependence and potentially alcohol, probably shows the most promise, but that's based on the limited published data.
Thank you for that. And it looks like we have just one last question. So increased self-acceptance, bless you, increased self-love and acceptance tends to be a common theme in entheogen experiences and healing. Do you find this to be an important component in the recovery process you experience with clients, or are there other common repeat themes that you see come up as important in healing addictions? You can see this in the question box.
Okay. So yeah, I think certainly, it's interesting what comes up, and so much of addictive behavior again arises from trauma, because there's such a it's complex, but it's why too we see a lot of dependence with people who experience childhood trauma, childhood abuse, also in PTSD among veterans. And so I think when we're able to use these molecules, these medicines, we treat them as sacred, in ceremony, which I think is critical for healing as well, in terms of setting and mindset. Certainly self-acceptance arises, as you mentioned. But I think when the default mode network goes offline, or is at least dialed down, the higher self, and call it what you will, consciousness, spirit within, whatever resonates, is able to act as a conduit to feeling connected to all. And so we get this telescopic perspective right? These molecules help facilitate this perspective that we don't get often day to day, especially, with the depressed and or traumatized mind. I think the substances are secondary. Again, this is my biased opinion, but again, aligns with Gabor Mate. That sense of isolation, is temporarily relieved. And so we're able to feel, and realize that like our existence is so much bigger, so much more than our addiction or our trauma, right? What's happened to us. Not to minimize it, but we're able to have a very different, very, huge shift in perspective in a short period of time. And I think that's what I see clinically, is that these medicines can be a catalyst, a tool to shift our perspective.
Excellent. Thank you for that. And it looks like we have just one final question. Where would one go to be trained and certified to work as a psychedelic-assisted psychotherapist, which...
Sure. So there are a couple of programs, and actually, Oren, you could probably speak to this a little bit too. So MAPS has a program specific to psychedelic-assisted psychotherapy. I'm not sure I don't know what their requirements are in terms of, being licensed and that kind of thing. So again, the MAPS website, you can check that out. For people who are licensed, there are many people like me, because right now, ketamine, I have found it to be just incredibly helpful for treating, mental health conditions. So there's trainings using ketamine. There's several different organizations that are offering that. And so the approach is it's basically the same thing. It's just utilizing the ketamine molecule. I think for most of these, they require that people are licensed. So at least like a registered nurse or a therapist or, physician, a nurse practitioner. And a few of those, one is Prati, P as in Paul, R-A-T-I, and they're located in Colorado. They've got a training coming up, I think, next month. So if you Google that, you'll find them. There's the Kriya Institute, Kriya. They're in California. I'm not sure that, with COVID right now, in-person trainings are few and far between, if at all. I did some training through the Ketamine Training Center, and this was organized by Dr. Phil Wolfson, and they're in the Bay Area, but they actually travel and they offer trainings in different areas. And then there is it Solaris? I'm blanking. There's one more organization in California. Polaris, I'm sorry, it's Polaris Insight. And I think they're in the Bay Area too. And so they have some ketamine-assisted psychotherapy, which again, it's basically the same approach, but just utilizing ketamine. They have some modules that are available online. And then once COVID, some of the restrictions, we get the green light, they're going to have some in-person trainings. I also have been offering some trainings here in Arizona. Again, licensed, people that are in, healthcare, mental health care. So I'm another resource, that's almost local. I'm in Tucson.
Thank you for sharing that. Now, is there anything, we're out of questions now. I'm sure I could talk to you all day, but is there anything else that you find important that we should add to this that you'd like to say to our audience?
I don't think so. I think just stay tuned. Again, it's an exciting time. Even when I was working on my master's, I just never imagined that there would be opportunities like this. Like I said, there was momentum way back, right, in the 50s, starting in the 40s with LSD, and unfortunately, we lost some time, but we're playing catch up, and we have the benefit of the internet and sharing information. The data is just, it's being published, and findings are being shared just at exponential rates now. So it's exciting. I appreciate you having me, and thank you for tuning in.
Yeah, no, our pleasure to have you. Thank you for joining us and sharing your expertise on everything. Thank you very much.
Yeah, that.
So our next presentation next month will concern grief in plant medicine. You can watch our Facebook page for any event details and to sign up for the events. If you want to support our cause, you can follow us on Facebook. You can talk to your friends and family about what you learned tonight. And you can also share this video. It'll be available here on Crowdcast, on our Facebook page, and on our YouTube channel. Thank you all for coming and sharing your questions. Have a nice evening.
Thank you.
Thanks, Jennifer.